Hello, everyone, and good evening to all. Happy World Physiotherapy Day to everyone. I'm Dr. Bona Rawal, and on behalf of IAP Digital Media Team, I welcome you today to today's webinar, which has been organized by Indian Association of Physiotherapy and IAP Women's Health, Telangana State. The celebration brings us with the topic return to sports post-COVID, and we have Dr. Himanshu Tiwari as our eminent speaker for the topic. This webinar is being live streamed on Zoom as well on our official YouTube channel, IAP India. And please stay tuned with us by liking and subscribing us on all our social media platforms. Thank you. And now I would like to hand over the session to Dr. Manjula.
Thank you, ma'am. I'm the moderator for the session, Dr. Himani Poddar. A very good evening to one and all, and a very happy World Physiotherapy Day to all. Myself, Dr. Himani Poddar, Sub-Coordinator IAPWC Telangana State. On behalf of Telangana State IAPWC, I welcome you all for today's webinar. The topic for the webinar is Return to Sports Post-COVID by our resource person, by our speaker, Dr. Himanshu Tiwari. Our Telangana state team function under the leadership of Dr. Sanjeev Jha, President IAP, Dr. Ruchi Vashni, Treasurer IAP, and Dr. Prabha Vinod, South Zone Head IAPWC. Our state team includes Dr. Hannah Rajshekhar, our state coordinator, Dr. V.V. Manjula Kumari, joint coordinator, Dr. Monima, sub-coordinator, myself, Dr. Himani, sub-coordinator, and Dr. Aisha, Hyderabad district coordinator. Now, I would like to request Dr. Hannah ma'am and Dr. Prabha ma'am to convey their greetings. Dr. Hannah ma'am, over to you.
Happy World Physiotherapy Day to each and everyone, my team members, and a special greeting to Dr. Himanshu and all the participants who have joined us. This is a wonderful session that we are going to have now from Dr. Himanshu, and I wish him all the best.
Thank you, ma'am. Yeah, so now I would like to request Dr. Manjula ma'am, our joint coordinator, to introduce and welcome our speaker for today's session. Over to you, Manjula ma'am.
Dr. Prabha is waiting to give the greetings.
Yes. Oh, yes. I'm so sorry. I'm so sorry, ma'am. Please, Dr. Prabha ma'am, welcome our speaker.
Thank you. Good evening, everyone. First of all, my heartfelt wishes to all the physiotherapists and my wishes to Dr. Tiwari also. And my thanks to Dr. Sanjeev and Dr. Ruchi. Physiotherapy is actually a noble profession. I'm always proud to say that I'm a physiotherapist. And I have a huge respect for Telangana team because Hannah ma'am is here. She's the senior most physiotherapist. And we have wonderful physiotherapists here in our Telangana team. And my best wishes will be always with you. Thank you so much.
Thank you, ma'am. Thank you so much, ma'am. Thank you so much. Over to you, Manjula ma'am. Kindly introduce our speaker.
Thank you, Dr. Himani ma'am. Thank you, Hannah ma'am, and thank you, Prabha ma'am, for being here. Thank you so much. And I wish a great, happy World Physiotherapy Day to each and every physio out there. I'm taking this privilege to introduce our today's speaker, Dr. Himanshu Tiwari. Dr. Himanshu Tiwari has done his sports rehab, and he's a performance specialist. He's a founder, director, and CEO of 69 Fitness Street. Director, Varna's Healthcare Research and Training. He has done his BPT and MPT in sports from Rajasthan. He is an international member of APTA, and he is also a member of RSPH. And he has done his sports performance catalyst from NASM. He is ACE Level 2 Sports Rehab and Performance Specialist. And he has done his FMMD from Spain. And he is a dry needling expert Level 2. FIFA medical diploma has also been done by him, sports and conditioning coach, and he has also done sports nutrition, and he has been a speaker in a lot of national as well as international conferences. Along with this, He has been awarded as Rashtriya Chikitsa Samman and Entrepreneur of the Year awardee of 2020. We are glad to have you here. Welcome to the session, Dr. Himanshu Tiwari.
Thank you so much for such an overwhelming introduction. And it's been a pleasure, and I thank Dr. Manjulat for giving me an opportunity to be here and share my knowledge on a very apt and a very hot topic, which is actually a kind of a trouble for people, also a scope of opportunity for therapists and doctors. It's a new vector in which we are learning, we are experiencing and experimenting a lot. So thank you so much. I am pretty keen and interested in this topic reason because I have been working with the first line team for COVID, and I'm also a certified awareness expert for COVID through WHO. So I have been seeing these cases very closely and observing things very closely. So it's actually an honor, and I'm really excited to share my knowledge on this. So thank you so much.
Welcome, sir.
So to start with, the topic, as everybody knows, that we would be talking about return to sport, as I am from a sports background, post-COVID. So post-COVID, as in the COVID issues which have been come up, or this the thing which is there, could be just a minute. I think I've lost the screen. Okay, yeah. Okay, so post-COVID means that either the COVID has ended, or you have suffered, or probably certain other issues. Now, when I am speaking, I would request the attendees as well to be attentive. So let's make it interactive. Definitely, I would not request you to unmute and speak, but we have a chat box. So feel free to put in your inputs through the chat box, and it'll be a fun and a pleasure lecture over here, right? So as the name of the session says, post-COVID return to sport. So what exactly do you think? What is the reason? What is the meaning of this topic? Is it post-COVID, as in the COVID has gone, or is it what the COVID is doing? What do you think? Type your input in the chat box, please. I would request everybody to be involved in the session. So also the team members, I would request the team members as well to please share their inputs. It will be an honor and great to have their inputs. Am I unable to see the inputs, or like Dr. Manjula? Ma'am, okay. Okay, now I can see. Okay, perfect. So, okay, we've got one says COVID mainly affects on the respiratory. I'm not talking about COVID. I'm talking, what do you think? Return to sport with COVID is what? Is it like return to sport in COVID? COVID has gone, or what do you think? What is your basic thought on the topic? What are we about to learn from this? I do understand COVID mainly acts on the respiratory system and the pulmonary cycle of the body. But what do you think we'll be learning with return to sport after COVID?
I think it's important to understand that you need to continue in whatever profession you're, irrespective of whether coronavirus is going to be there. And so for a sports person, returning to sports and learning how to, live with this COVID for some time is important, as well as the musculoskeletal involvement and cardiovascular or pulmonary involvement that could deteriorate his performance. But how he conditions himself, comes back, performs, takes care of himself, keeps safe, all those things are important for him.
Right, absolutely. So this is definitely one of those points. But Okay, we've got one input: return to field after lockdown from being suffered from COVID. Definitely, yes. This is again one of the very important point, getting back to the field post-COVID. Okay, this is also a very good point. A way to return back to normal without any setbacks. This is exactly what I was looking forward to. Thank you so much. So exactly, we would be looking forward to a way to return back to normal without hindering our performance, without facing any challenges, even after the COVID has hit on us, maybe socially, physically, mentally, psychologically, etc., etc. Right? So today we'll be learning about this. Next slide, please. So that's my brief introduction, as I've been already introduced. I'm a CEO and director for 69 Fitness Street and Vernas. Plus, Rebounds is one of our very known entity which helps and which actually is responsible for learning in different genres and respects. These are some of the trusted brands, few of the brands which I could place on the page, with which I have worked and I'm working, and they've trusted me and my brand on it. So these are this. Thank you. Next slide, please. Okay, now this is very important. By end of this lecture, by end of this session, what you would be able to understand is what is the exact role of PT in managing such kind of cases, patients or athletes. Okay, when an athlete is suffering from something and he's facing issues, then he's a patient, right? So I've mentioned patient over here. After that, we need to understand from where these patients are coming. Because see, once the athlete is not well, is sick, he's no more an athlete at that time. He's been released of the team, he's been released of the club. So we need to understand from where we'll be getting these patients, right? Third is, what are the safety parameters and how to enter into the program which will help you return back, right? So this is the third thing. Fourth, we'll be understanding what should be the setting of the program, maybe inpatient, virtual, independent, or whatever, right? How to understand the setting, the framework of the program. Next would be what the program consists. We've been talking about programs, how to enter, safety parameters, and what exactly the program is. We'll be learning about the program as well, right? What are the parameters after safety? What are the guidelines? What are the things we have to take care of? The parameters, so that the patient returns back as an elite sports professional, right? Our basic outcome being a sports physiotherapist or an MSK physiotherapist, our basic approach should be how quick and how efficient we have to bring the athlete back on the field to train with the best of his capabilities and reach to the best of performance, right? So that is exactly what is our need. So by end of this lecture, you will be able to understand these points. Next slide, please. Now, when we talk about COVID, okay, we know what exactly COVID is, how COVID affects, what precautions we have to take. I do understand, right? But apart from this, what exactly the impact has been created in the sports fraternity, in the sports industry by COVID, I'd like to share few data. It could be a bit boring, but just try to grab these data, because these data will actually help us understand the affection and the impact on the sports industry and how we have to overcome it, right? So in the sports industry, the extent has reached till 11%, okay, and the infected person were being admitted into ICU on artificial respiration, right? So COVID definitely acts on our respiratory system, and they were on that extreme that they were on artificial respiration. Now, let me take one thing very clearly. An athlete is a person who's on his best of his capabilities. He's got a very good vital capacity. He's got a very good system within the body. He's got a very good physical structure. So his immunity is also very strong. And if an athlete is on that level, wherein he is on an artificial respiration and he's admitted in ICU, that means the affection is really on a next level, right? So this is really a big concern for us. Next point is 50% of the individuals which are affected by COVID were prolonged to stay in ICU and have developed critical illness polyneuropathies. Okay, there were multiple issues which were being observed in that individual. Okay, and most of them were asked to stay for a longer period of time in an ICU. 65% will have functional deficits post discharge or post recovery till next 1 year. Now, functional deficit means maybe their taste goes off, their smell goes off, right? Probably their lung sufficiencies could have been hampered, their performance, their fatigue levels have been disturbed, right? So there are functional deficits in an athlete who's affected by COVID, recovered even after recovery for next 1 year, he would be facing challenges. So this is again a very strong challenge point for us, because the athlete would be looking forward to us and he'll be expecting some kind of a protocol or some kind of magic from us to help him out and reach to the performance which he was before the COVID infection, right? So this is very important. Now, let me give you one more thing. Up to 30%, this is an experienced fact, up to 30% of the recovered patients were facing cardiac issues for sure. This is what we've experienced. This is what we've seen. So in 65%, we have seen 35% facing cardiac issues. So their cardiopulmonary rhythm was being disturbed, right? So this is again a challenge. Next slide, please. Now, going further, in those 65%, what we've seen is for next 6 weeks after being discharged, for next 6 weeks, 40% of them were facing dyspnea. Okay, 32% were facing sleep disorders. They were unable to sleep. And let me quote it, that sleep for an athlete is more than a Jeevan Rask hole. Let me tell you, really, sleep for an athlete is like a magic for them. It's like more than a platinum, right? So that is very important. So 32% of them were unable to sleep repeatedly for a couple of days, right? 26% of them were facing severe anxiety issues. They were unable to understand, they were unable to gauge their own body, and they were not ready to accept that they are recovering, right? For an athlete, his mental equilibrium is very important. And if he faces anxiety issues, it's a question, it's a challenge for the entire team, for the entire coach, for coaches team, for the entire officials which are there, right? Imagine Sachin Tendulkar, being one of the most important and efficient player in the Indian cricket team, faces anxiety when he's there on the pitch and he's unable to understand what kind of ball is coming in. The entire crew would be in tension, right? So the same thing happens if the player is unable to understand his own physiology, is unable to understand the environmental factors, and he's into severe anxiety issues. He would never be able to come out of it. And what he would be thinking is that now I'm done, right? So that is a very major problem with athletes. They are pretty strong, but in this scenario with anxiety issues, they are very weak. So we have to work on them. For 6 weeks, they face these problems on a very severe extent. Right. Next, these are the scientists which have which have created, which have written journals, which have written articles on these data, and they've done research on the community, on the sports community with a group of athletes, right? And they've given their research work. In the end, you can get the things, right? Second thing, 12% of them were very fortunate to recover in next 60 days. 60 days is again 2 months. Okay. So that recovery was 100%, but with functional deficit. So they were certified as negative from COVID. They were back with their capabilities, but some of them were facing taste issues. Some of them were facing smell issues, right? So there were functional deficits with them, right? Next, 52% of them were facing fatigue issues for 10 weeks. See, as I mentioned, okay, incidences unrelated to severe and acute diseases. What does this mean? When we are actually talking about it, it means that for next couple of weeks, they were facing issues with their immunity, they were facing issues with their breath rate, they were facing issues with their heart rate as well. So these issues were actually troubling them not to reach out their peak performance level. Next, 51% of them were having at least one symptom which they were struggling through COVID. Okay, one symptom was persistent. So probably gasping was there, or probably mild nagging fever was there. Probably the smelling capacity was not there, right? So one of the symptoms was there, which should state that this person or this athlete was suffering from COVID. 19% of them have seen abnormalities in their chest imaging studies. So this means that, and 9% were facing spirometry abnormalities. This clearly states that damage which is caused by COVID is irreversible. Yes, we've seen cases wherein there's a severe lung lobe damage while the COVID issues, and those lung lobe damage was not reversing. So the problem was there, and if the damage is done, it is irreversible. Next slide, please. Now, as we've been facing these issues, as we've been seeing the multidisciplinary problems, we should understand that as we're dealing with multidisciplinary issues, we have to create a team which should carry a multidisciplinary approach, right? So keeping these things in your mind, a team with doctors and multidisciplinary physiotherapists was actually created, and a research was done on COVID patients by a scientist called Davies and Becker. Okay, and they said that if we create a multidisciplinary team on these COVID patients, the recovery is even much better and faster, because we are dealing with respiratory issues, we are dealing with cardiac issues, we are dealing with MSK issues, we are dealing with ortho related issues as well. There are issues with the joints sometimes. Okay, so we have to create a multidisciplinary team. Definitely, yes, it is a challenge, but if we create a multidisciplinary team, we would be able to take care of the patient, of that athlete timely with periodic events, right? There would be overlapping sometimes, and yes, it is important to have an overlap with therapists and doctors at the time of execution of the protocol, and that is important. So do not hesitate in overlapping of the program, of the protocol, right? As in, like, if MSK is working and if a cardiopulmonary PT is there and he want to do it, do not hesitate to work together, right? That will actually help you and the patient work better and recover faster. Next slide, please. Now, most of the hospitals, okay, the patients, when they were discharged, they have referred the patients for PCP. PCP is post-COVID program. Okay. And when they were being referred to post-COVID program and the patient opts for that program, we have seen 90% result in the recovery. The functional deficit has also been recovered faster. Definitely, we've seen that it stays for 1 year, but that is the maximum extent. We've seen recovery even within 60 days, right? So multidisciplinary approach is very important. Now, from where we'll be getting these clientele, these patients? It could be from the primary care as in the hospitals, the family medicine team, as in your own family doctor, or direct access, as if like you know somebody who's facing COVID issues and you are directly assisting the patient. So you are allowed to assist the patient directly as well, but definitely keep a doctor in loop so that the other issues or the therapeutic issues are being taken care and administered properly, right? Next slide, please. Now, from this, we see that there are mixed opinions for things, right? But what we are concerned about is the mortality rate, right? The patient should not die. There should not be a wastage of a life, right? So nobody is small or nobody is big, nobody is superior or nobody is inferior. If you are able to work in a team and help an individual or help a patient get back on his feet with maximum capabilities and performances, right? So if we are able to achieve a better gain in mortality and QOL with proper rehabilitation, definitely whatever approach you take, not specific this program or that program, if you're able to achieve this, I tell you, you've done the job. Okay, so do not hesitate. So don't think about that we are not allowed to do this or the other person is allowed to do this. Nothing of that sort. What your basic approach or basic requirement is to achieve best of rehab and QOL. QOL is quality of living, right? Post-COVID, things have changed a lot. The living and the mentality both have changed. People have started to get afraid. Okay, they have their mindset that probably this might affect us with the infection or without the infection. They are restricting themselves, right? So this is actually in turn hitting very badly and negatively on the quality living of an individual. So we have to be equipped enough, and we have to make them understand that quality of living should not be hampered, and we have to work as per that, right? There are evidences that exercises mitigate anxiety, and yes, we know that when we do workout, anxiety level and stress levels, they go down. So that's absolutely okay. A supervised 6-week program produced significant effect and improvement for strength and cardiovascular fitness. Okay, this actually in turn help you to lead a good quality life, right? Definitely there are issues which deal with myopathies, polyneuropathies, polycarditis, myocarditis. Definitely, yes, we have to understand and deal with these issues as well. That is the reason why I said in previous slides that we have to create a multidisciplinary team. Never hesitate in referring to doctors and other professionals. So that's absolutely okay. Next slide, please. There was a very good research which was done by a team of professionals. I personally like that research, and I would like to just respect those professionals by saying their names. It was Dr. Fahad Hamid, Eugene, Abhishek, Dr. Abhishek Jayant, Dr. Remy Said, Dr. Corina, Dr. May, Dr. Vandana, Dr. Amy, Dr. Alfred. So these are few of the doctors, PhD and doctorate in physical therapy. They have actually created a research, and a journal was being published saying that the recovery program of the patients facing with COVID-2, the second strand, the second mutation, was much better if we execute the program post-COVID for physiotherapy, right? So PT is one of a very important and most needed tool for patients' recovery who are facing issues with COVID and the further strands of COVID, right? So what the study cohort is, next slide, please. In the study, they took the group of around 106 patients. Okay, these 106 patients, why only 106 patients was, these patients have given their consent upfront that yes, they are ready to help them out with the research. So there were 106 patients who were being discharged. Okay, in 106 patients, 44 of them were ready to take a virtual session with the PT, right? The other of them, 25 of them were ready to allow them to come at their places and give them the PT sessions. 17 of them were there. They said that you give us the program and we'll try and execute it by ourselves because there are certain other constraints and probably their family issues were there. Remaining 20, they said, we will follow this. We will follow this if things feel better. So they did not give any kind of confirmation, right? The outcome was measured on the 30-second STS test for LE strength and 2-minute step test for endurance. These tests and these outcomes were observed for next 2 weeks, and they were reassessed. So before starting the program, they were measured. They were actually assessed on these tests, and after 2 weeks, they were again reassessed. Okay. Now let me rule out things that the multidisciplinary team was well equipped with psychiatrists and a neuropsychologist as well to keep them motivated to follow the protocol for physiotherapy. Second, these patients were on a regular follow-up sessions. Only 50% of them, including the 20 which opted not to do PT, dropped out from further follow-up sessions. Okay. Plus, the home PT was continued by the patients and the therapist as the followed up progressive plan. Okay, even when we've got the proper the recovery of the patient, then too they were actually continuing with the program. Next slide, please. Now, what exactly the tests were? The tests were actually 30 seconds sit to stand tests for lower extremity strength testing. Okay, that was actually conducted. Plus, pulmonary rehab and home PT groups were taken into consideration, right? And the clinical meaningful improvements were documented. They were actually taken in consideration, but no exercise and independent exercises were being advised to them, as in like the entire workout, whatever the treatment protocol is being given to them, was actually done in the presence of the therapist under his observation, right? Plus a 2-minute step test was also done for cardiopulmonary endurance, which was done in the presence of the cardiopulmonary rehab group, and a clinical meaningful improvement was documented. Nothing else was done except these 2 things. Next slide, please. This was actually rolled out in September. The results were being documented. Okay. And the meaningful improvements clinically was documented, and they were actually distributed to the team, staff, and the resources. Plus, they were also trained how exactly the program has to be executed, so that the program and the protocol is not just limited to the therapist, but the staff can also help in them, right? Virtual clinic options were also being explored, and there were more than 450 referrals which were being worked out with this protocol. So not just 106 patients were being benefit. After these 106 patients, when we've done with the awareness campaign, these patients also referred other patients, and the doctors and the experts who were dealing with the COVID issues also referred their patients for PCPs, post-COVID programs, right? And under me, I personally have treated more than 500 cases post-COVID, and personally, I have got more than 90% of the success rate with their recovery, including their improvement in the functional deficits as well. Next slide, please. So, in this slide, we'll be understanding what are the positive COVID symptoms and how we have to go ahead with it. Okay, so when we actually start with the COVID treatment, what we see is we see fever. Okay, with that we start with the medication for improvement of fever, cough, and shortness of breath. Okay, now once the recovery is being done, what we take care of is the test for COVID negative or not. If yes, then we go ahead and proceed with the post-COVID protocol. If no, then the patient is again sent back for the further treatment of the COVID-19, right? When we see that the test is negative, okay, what do we see is we see that there should be consistent recovery for next 24 hours, and there should be no fever, no cough, and respiratory improvement is being documented. After this, we do observe for next 10 days how the symptoms are improving as in towards negativity. Okay, the patient remains negative and the insufficients are getting better for next 10 days. If they roll back, we again get back to the treatment protocol. Okay, now these were for the patients who were with symptoms. We've seen issues wherein the patient said that we are getting a report of positive, but we are not showing any symptoms, right? So then what to do with them? We have to be sure that they are tested negative, right? And that negativity should persist, right? 10 days since positive, since they were said as positive. This means when the first report of their positive was being seen and the treatment started, they until the date they've been negative. From that 10 days, we have to observe that they are not getting back to the positive report. A bit confusing. Let me make it more clear. A patient is suffering from COVID, tested positive, treatment done, therapeutics, tested negative. Now from that negative day, they see next 10 days and they see the persistent negativity. So once the test has been done, after that, after 1 week, we again do the test, the RT-PCR. Okay. After the RT-PCR is negative, for after 7 days, we again do the RT-PCR for next 10 days. Okay. Those 10 days are again under observation and we see that there are no symptoms, plus the report is consistently negative. If it's consistently negative, we are assured that yes, the patient is negative now. He is no more affected with the COVID. So these are the things which we have to take care before assigning a program or a protocol to an individual. Next slide, please. As we proceed further, when we are sure that the patient has been certified as negative, we then too would require a medical clearance from the physician, a medical clearance from the cardiologist that he is no longer facing any symptoms or any issues cardiologically. The SpO2 should be more than 88% to perform any physical activity, not the high intensive trainings or sport activity, but to perform physical activity. Physical activity can be anything. So your daily routine is also a physical activity. So SpO2 should be more than 88% to perform that, right? Plus, if any activity shows depreciation of the SpO2 below 88% or is drastically reducing by 10%, you have to stop that activity or an exercise and immediately consult the doctor. Okay. Plus, there are certain protocols we all know, positioning, huffing and coughing, etc. we can do to help and facilitate the patient to increase the efficiency of SpO2, right? But we have to keep a physician in loop with that. Proceeding further, the heart rate should be less than 50 in the resting phase and more and around 140 in the active phase. The systolic should be around 90 or less than 90, and diastolic should not be more than 200. Okay, if it increases more than 200, it should be discontinued. The exercise or the protocol which is there should be discontinued. The systolic one. If it increases, there could be an onset of angina. Okay, there could be an onset of cardiac arrhythmia. There could be an onset of any cardiopulmonary issue. So anything happens which goes beyond 200 or which goes beyond the maximum range, we have to immediately discontinue that protocol and seek for an emergency care. Rush to the hospital or rush to the doctor, go for the first aid protocols and immediately get the patient admitted back to the hospital. Next slide, please. Patients should be again and again re-screened for infections, because once treated from COVID doesn't mean that you will not be affected. Okay. We have got one question. I'll keep addressing the questions side by side because we might leave that point over there and it would be really tough for us to go back. Okay. I have suffered from critical COVID infection conditions 2.5 months back. Dr. Aditya is saying that. I started cycling about 3 kilometers per day. I continue the same, or shall I go on improving the distance? This question, Dr. Aditya, please keep this question with you, because this would be answered in the last when I'll explain you the program. Okay, so I'll tell you this. Just hold on with this question. Remind me again in the last, right? Thank you so much. If the patient is negative but symptoms, okay, when the patient is negative, okay, if the patient is negative, then it is negative, right? Symptoms will not be there. Functional deficit can be there. Okay, see, try and understand. When the patient is positive, there are two scenarios: positive with symptoms, positive without symptoms. Okay, positive with symptoms, communicable. Positive without symptoms can be non-communicable. Not exactly, can be non-communicable, right? So in these situations, but once the patient is said and certified as negative, it's negative. The symptoms are finished. Then only is being treated, and then only the patient is negative, right? So it is that. We worked with COVID wards and checked the SpO2 continuously with the patient is maintaining 96. We used to go for 6-minute walk test. Yes, this is a very good test, and that actually helps you to understand if the SpO2 maintains persistently constant, or is it dropping. Is there a lung insufficiency? If there would be a lung insufficiency, the SpO2 will tend to drop when the physical activity will be starting, right? So this thing happens. So 6-minute walk test is really a good test, right? Proceeding further, pulse oximeter should be handy and should be closely monitored. Okay. Rating with exertion should be taken care. Pain and functional scale should be measured very regularly. Okay. Receiving oxygen supplementation can attend the same rule. Okay, so we should be ready with a medical clearance before starting with any kind of physical activity, because if the patient is on artificial respiration, he has to be off oxygen when he will be on the physical activity. So you should have a medical clearance from a physician. That is very important. Okay, next is cardiac symptoms. So you have to be very clear and with the clearance from the cardiologist that he or she is not facing issues with any kind of cardiac issues, specifically myocarditis, okay, or any cardiac arrhythmia. So you have to be very clear and specific with that. Okay, plus lower extremity DVT should not be there. Okay, make sure that lower extremity DVT is not there. Okay, next slide, please. Now, when we actually start with the protocol, we start with the 8-week program initially. Okay, with the athletes. I'm not talking about regular patients or normal people. I'm talking about athletes as we are focusing towards return to sport. Okay, so we start with 8 weeks program initially, and that treatment, that program is 1-to-1, not in group. Okay, this is very important. We have to be 1-to-1 with an athlete, because we have to work on his return to sport and not just recovery from COVID. Okay, so COVID recovery, we can go ahead initially from 1-to-1 proceeding towards group exercises, but with an athlete, you have to continue with 1-to-1 protocol only, right? So that you are able to gauge and judge the performance and other vital stats directly, real time, there and then. Okay, now there will be 4 overlapping stages. One is the basic, the baseline measures taken in the unique program constructed based on the patient goals. Okay, patient goal. Now for us over here, our goal is to return the sport. Okay, so we have to create a measure, we have to create a protocol, okay, which should give us a basic approach first, then the return to sport, and then the performance efficiency. Okay, so we have to create stages, and then as per that we have to create the program. Okay, get working. So we have to manage with neuromuscular coordination. We have to make sure that there are no symptoms and no deficit in the neuromuscular coordination. Okay, the thoracic mobility should be better. Breathing patterns should be addressed and made more efficient and better. Okay, manual therapy and exercises should be a mandate and incorporated. That is very important. Then only you will be able to manage with the neuromuscular skeletal coordinations and efficiencies, right? Next thing, you have to be very cautious and very closely, minutely observant on aerobic and anaerobic kind of a switch, because there will be respiratory insufficiencies, as COVID definitely works and hit on the cardiopulmonary issues, right? Plus, the strength training should be monitored very closely. Now, when I talk about strength training to be monitored very closely, means it is of utmost priority, because strength training, if not taken into clear and great consideration, can create severe problems. I repeat, severe problems. Okay, we'll see further what problems can be there. Get back to quality living, functional goals should be achieved, and independent exercises should be achieved by end of the protocol. So it should be a clear, easy, smooth transition from one-to-one physical therapy sessions to an individual independent exercise sessions, right? So maintenance and follow-up should be done in a very smooth transition. Next slide, please. There should be a proper incentive which should be given for spirometer, okay, and respiratory symptoms should be taken into clear consideration. We have to understand and help the lung capacity should improve. The expansion should be taken care into clear consideration, right? Now, as we go ahead, as we are talking about respiratory symptoms and respiratory insufficiencies, we have to be very clear and very sure that there is no involvement of headache or symmetric thoracic pain. Can anybody tell me why are we focusing majorly and specifically on headaches and thoracic pains? I want you to give me your inputs in the chat box, please. When we are dealing with respiratory insufficiencies, respiratory symptoms, why are we basically focusing majorly on headaches and not on the spirometries? Why are we more focusing on headaches and symmetric thoracic pains and not on spirometry data? Why? Any inputs, please? Why are we focusing more on headaches and symmetric thoracic pains? Anyone? Okay, I'll tell you. So when we are actually dealing with respiratory insufficiencies, okay, the major thing which gets hit when we are actually performing physical activities or a training session or any kind of activity which involves our respiratory rate and cardiac rate, it actually gives you a hit on SpO2. And when the SpO2 is being hit, there is reduction in oxygen content, the volume of oxygen within the body. Okay, if there is a hit on the volume of oxygen within the body, our head goes on a toss and we get headaches, persistent headaches, progressive head spins as well. Okay, symmetric thoracic pain has been mentioned because when such thing happens and we face insufficiency in the oxygen in the body, there is a negative pressure which gets created in your thoracic cage, and there is an what do you call, there is a nagging and an insufficient pain which is there in the entire thoracic cage, which is because of a negative pressure which has been created within the lungs, and that actually creates the pain, and it persists and it increases as well. Okay, if it increases to a next level, it can be fatal as well, right? So that is the reason it is important for us to be sure that the respiratory symptoms are being taken care very minutely and closely. Okay, thoracolumbar manipulation and manual therapies should be taken into consideration. Soft tissue massages and respiration with diaphragm and other lung lobes should be practiced. Now, there is a compliance. Compliance is, there is a challenge because these patients have been facing a lot of issues. Okay, they will come up with anxiety and depression issues. The player will say that, sir, now my capacities have gone down, so probably I would never be able to reach out to my best performance level. So there's no point. You'll be getting severe depression and anxiety issues. That can also give you a feeling of brain fog, right? So these are the things. Next slide, please. So when we are dealing with the respiratory symptoms, right? For these respiratory symptoms, we have to be sure that the exercises are being planned in such a manner that there should be at least 3 METs which should be incorporated in the program, right? Plus aerobic exercises which should progress from 20 to 30 minutes. Balance exercises which should be incorporated 3 to 5 times per week. Okay, and their maximum capacity should be achieved, right? It should be progressive. It should not fall back or stay, because if it stays, if it creates a plateau, that is again responsible for a low performance level, or we would not be able to reach out to the peak performance which we should acquire, right? Next is strength training. Again, now this is a very important point. Strength training should be progressive. Okay, it should be 8 to 12 RM load. Okay, 8 to 12 repetitions, 1 to 3 sets. Now try and understand. 1 to 3 sets is again a progression from starting from 1 set, progressing towards the 3 set, starting from 8 reps, progressing towards 12 reps. Okay, the 1 RM load should be managed. Okay, 8 to 12 RM of the load should be calculated and used as per that. You should not be going ahead on an ego trip and when you're doing strength training, now we need to take a feel and go ahead and lift heavy weights, go ahead for a very intensive exercises. No, please don't do that. That is very risky. Okay, and if not administered properly, probably that can be fatal as well. So please do not go ahead with the ego trip. Go gradual, achieve a set stipulated target, and then we can do the assessment and see what kind of improvement clinically and therapeutically we've achieved, right? Rest is very important. So between sets, there should be a proper complete rest, not just to recover the fatigue, but your vitals should also go down to normal, right? So 2 minutes should be the rest time which should be given. If the rest time is exceeding 2 minutes, probably your treatment, your protocol, or the training schedule which you've made is more strenuous or more intensive as per that situation or that level of the patient. So bring the level down, let them go back to a lower level, and then proceed further and progress further, right? So 2 minute rest, take it as a benchmark that 2 minutes should be taken for the entire recovery before the next set starts. Okay, this protocol should be done thrice a week for 6 weeks. Okay, this strength training protocol, you should not go ahead regular daily, or you should not go ahead with a compartmental strength training. Excuse me. There should not be a compartmental strength training as we do, like today we've done chest, tomorrow we'll do back, next day we'll do some other stuff. No, it has to be a combination full body training probably, which can help you to work on the entire body simultaneously all together. 3 times a week for at least 6 weeks, not less than 6 weeks. We might proceed further with 6 to 8 weeks or probably 10 weeks, but not less than 6 weeks. 6 weeks is the least minimum practiced duration. Next slide, please. Now, over here, there is a case study. Okay, this patient, we've written the name as KZ because the patient has not allowed us to use his name. It's a real-time case, and I've treated this patient. He's one of the athletes for a football club, and he was being certified as COVID positive. And after his recovery, we executed the program on him. He's a 25 years of age player, and he was referred for PCP with weakness and hypoxemia, right? He was hospitalized but not ventilated. Now, there is again a situation. The patient has a complaint of hypoxemia, but he was not ventilated. This means his breath rate was fine, but the oxygen carrying capacity was less, right? He was facing LBP, low back pain, because immobilization was there. He was on bed rest for a quite long time. His fatigue levels and respiratory symptoms have increased. Okay. And he was asked to attend 12 visits in a stipulated period of 30 to 33 days. So probably 1 month. In 1 month, he was asked to visit 12 times. Okay. What did we achieve from that? Next slide, please. Okay, so after the program was being executed, what was the change we observed? Okay, before the starting of the program, we evaluated. Photo was around 40. Okay, then the LBP, which was at the 8th grade. Okay, it was there on the 8th grade. The standing endurance was 0 to 10 minutes. Okay, the lower extremity strength was 70 to 50%. Heart rate was 105. Blood pressure was 106 by 62, and respiratory volume was 1300 ml only. Definitely, as I said, the patient was not on ventilation, so SpO2 was 95% as per the oximeter. By the end of the protocol, what we expected was we would be able to reach to the photo level of 62, but we were overwhelmed with the result. We got 80. Okay, so photo is basically, it's the focus on therapeutic outcomes. Okay, it's a scale which helps you to understand with therapeutics, what are the things you were able to manage properly, what are the positive changes, and how the patient has progressed and improved clinically, so that we can document it on a scale, right? So this is the photo scale. LBP on the VAS scale was seen that the pain has gone down to a level of 3 after the program was being executed. The standing endurance and the physical activity endurance was increased from 10 minutes to 60 minutes. The lower extremity strength was increased to 90%. Okay. The heart rate was managed and controlled to 67 during the physical activity. Okay. The blood pressure was achieved on the scale of 112 by 72. The inspiratory volume, okay, which was 1300 ml only, was observed to reach by 2000 ml by end of the protocol. Okay. As the inspiratory volume improved, we've seen the improvement in the SpO2 capacity also. That was 97%. So the oximeter said 97. So these are the data which we've observed after the execution of the PCP, post-COVID protocols. Next slide, please. Now, when we talk about the results, what exactly we did? Okay, what exactly we did? So the treatment or the program included breathing pattern facilitation. So that was actually diaphragmatic breathing and basal expansion. These are the basics, the approach which we focused on. The thoracic manual accessory immobilization. So there was a clear manual manipulations were being done for thoracic, and mobilizations was done for thoracic. Soft tissue massage was engaged for hip and a lumbar region, because the patient was on bed rest for a longer time and not on any major activity other than normal walking within the vicinity of the room, right? Next step, the next slide, please. For 1 week, we focused on breathing and mobility of thorax. Only breathing, wherein we initiated, when we encouraged diaphragmatic and basal expansion breathing, okay, for 1 week. Next, we were able to commence strengthening exercises from day 3 after the 1 week. Okay, cardio exercises were being commenced from week 2. That is after 1 week, the week 2nd, we've started with the cardio exercises as well. Okay, and mild strengthening exercises were incorporated from the 3rd day of the week 2. Okay, functional exercises progressed from sit to stand to visit 5. Okay, progress to standing and walking. So earlier we used to do sit to stand, okay, sit to stand and then go back to sit, which was progress to sit to stand, walk, and then again sit. Progress to stepping exercises, as in stepper walking, step up, come down, okay, step up on a box, come down. These were the progressions which we've observed, which we've done with the functional exercises, and the progressions were being achieved. Next slide, please. Biochemically also, the investigations were being taken into consideration, and we've seen that the signs of cardiac diseases were lowered. Okay, the risk on the athlete was reduced. Okay, severe position statements and the guidelines were being produced and asked the patient to practice on his own. So the postural positions, the drainage, and the lung facilitative positions were being taught to the patient and asked him to perform in front of the therapist and in the absence of the therapist when the patient is in the treatment protocol. Next slide, please. Now, as per the protocol was being done and the research was being done, Stanford Hall position states that patient returning to high-level sport or physically demanding occupation following confirms myocarditis requires 3 to 6 months of period for complete rest. What does this mean? If an athlete actually is committed for a return to sport protocol, the program has to be continued for at least 3 to maximum period of 6 months with no intensive or no high level physical activity other than walking. Okay, so these exercises of the protocol was being executed and the patient was asked to stay from 3 to 6 months with a regular assessment protocols. Okay, 3 months is the minimum time wherein we see that okay, the recovery is proper and consistent, so we ask the patient to be discharged and go ahead. But when the patient is not being discharged and we are working on it, probably after 3 months, if we see that there is further scope of improvement, we ask the patient to stay and prolong his admission within the vicinity and stay there for a more longer time, so that we can work on proper recovery and maximum performance potentials. The period of rest is dependent on the clinical severity and duration of the illness. Definitely, yes, it states itself. Left ventricular functions on the onset and extent of inflammation on CMR. So the onset and extent gives you an opportunity to understand how level of improvement can be achieved and what is the extent. Next slide, please. Further, Stanford Hall says that training, next slide, please. Training may resume. I request for the next slide, please. Thank you. Training may resume for high-level sports following with myocarditis if the left ventricular systole is functioning normal. If the left ventricular systole is functioning normal, the biomarkers of the myocardial injury is normal. Okay, the biofeedback is normal, and there is no relevant arrhythmia for next 24 hours monitored under the exercise testing and ECG on a continuous basis. So after being confirmed by these protocols and these tests, we certify that the patient or the athlete is fit to perform physical activities other than mild or moderate. Okay, so we have to be sure and available with the 24-hour ECG and exercise testing report and a clearance certificate from the cardiologist that the patient is no longer facing issues with myocarditis. Because if we see that the patient is there facing issues with myocarditis and we incorporate any kind of strenuous activity, the rib cage or the thoracic cage will go into a negative pressure, and this can be fatal, right? So you have to be very clear and very sure. Next slide, please. If returning to high-level sport or physical demanding occupation following myocarditis, the patient is required to undergo periodic reassessment for a particular duration for first 2 years after the recovery has been observed. What does this mean? Let me make it more simpler. If the patient was facing myocarditis at the time of COVID infection, he is being certified as negative, okay, and he is been showing improvement in myocarditis, then too the patient is required to visit for reassessment for the first 2 years from calculating from day 1 of the recovery. The patient was said as negative even after the 10 days observation. From that day, the patient has to be reassessed for next 2 years. That is very important, because if in case we see any kind of insufficiency in the cardiopulmonary system, it can again create a challenge. And for an athlete, because they are into a very high pressure and intensive environment, they have to be very fit with the cardiopulmonary issues and cardiopulmonary strength. Next slide, please. Now, we have seen that the patient is fit to go ahead and train, right? So the lockdown has been lifted. The player is very happy. The player is very happy. He started with his training. He started visiting to his team. His coach is very happy. Everything is very good. Now the challenge increases for a physiotherapist who's there with the team or who's there working with that particular patient or an athlete. How? The lockdown has been lifted for the athlete to perform intensive or high intensity training, right? But at the back of the mind, he knows that he's recovered from the COVID. And we know that there are functional deficits as well. There are pulmonary deficits as well. So how we have to be sure that is the thing proceeding further properly or not, right? For that, what we say is that the report which we file in for the coaches or for the players, we say that the player has graduated to return to sport protocol, but there has to be a performance graduation as well. Okay. So what we do is we keep a very close observation, very keen observation on that athlete, stating that what kind of vital changes have been seen when he is actually into a very intensive training environment, or he is into a match scenario. These things have been taken into consideration during the season or pre-season initiation periodization protocol. Now let me make it understandable. There are 3 phases: pre-season, in-season, post-season. Okay, so in pre-season we have 2 phases. Pre-season, as an initiation of the pre-season training protocols, training starts with the team. Okay, and then that is transition from pre-season to in-season. So transition from in-season to season is actually pre-season, in that you experience and experiment and take the performance level to a next height so that they perform at the best of their capacities in the seasons during the competition. Now, when they are geared up for the competition, you as a physiotherapist should be sure and skilled and equipped enough to manage with the insufficiencies. How? You have to keep an eye a very close observation on breath. Okay, you have to be very close and understanding, is the patient getting diarrhea or nausea frequently, or any episodes have occurred? Okay, is there any kind of dry cough? Is there any kind of vague fever or a marginal fever, even if he says 98, 99 or 100? Okay, the marginal fever is also there or not? Is there any kind of loss in the functional deficit, mainly smell or taste? Okay, if the thing persists for a longer time, you know how to go ahead and the patient or the player is asked to go back to the PCP and follow the entire program. Okay, follow the entire program for conditioning, follow the entire program for strengthening, follow the entire program for recovery protocols, right? If you see any kind of these insufficiencies, you are responsible enough to take care of the initial protocol and then help the athlete get back to the graduation position for return to sport. Okay, that can be from 7 days to 10 days, right? Plus, if the treatment is going on, the patient is on paracetamol, make sure uh, you are actually keeping an eye on the ECG of the patient as well. Okay, there should be no rolling back to myocarditis. That is very severe and it happens. If everything goes okay and you are able to manage with the entire thing properly and the patient is still negative, he is fit to go ahead and play in the intensive environment, right? Now, when we talk about he's fit to go ahead and play in the intensive environment, means that the player has been given a green signal to be considered for competition. Okay, the player has been given a green signal to be considered for the competition. Now, when the player is being selected in the squad for the competition, our work increases, right? Because we have to deal with functional insufficiencies as well. So there is a stage set protocol approach, which I and my team has also used it, and it is actually based on a proper research. Okay, what is this protocol? Let's see. Next slide, please. Now, this protocol comes into stages. Okay, there are 5 stages. In the first stage, we carry this first stage for 10 days. Okay, in those 10 days, we do not give the patient or the athlete any rest. Rest is bare minimum. If you're sleeping, okay. If you're not sleeping, the rest is a bare minimum. Hardly any rest is being given to the patient. But what kind of activity is being performed with them? The activity is walking, daily routine activities, as in like taking shower, bathing, right, changing clothes, cooking, or managing the household stuff. Okay, so these are the daily routine things. Okay, and you have to be on your toes. You have to keep walking. No settling down business. Okay, the activity, you have to be sure enough that the activities should not be intensive in the stage 1. We do not need any kind of intensive activity because the vitals and the body is not ready for that kind of strenuous input, right? Definitely, yes, that we've given a green signal and the player is very excited. He would definitely want to jump on it, but we need no kind of insufficiency should be bothering to the player, right? So for first 10 days, you have to give the player or the patient walking and daily activities to the maximum. It should not be like, okay, you've just recovered. No, rest. I'll take care. I'll do it for you. I'll get that thing. No, let the person perform all the daily activities to best of his capacities, wherever and whichever he wants to do it. Okay. Next is duration. It should be 10 days. 10 days, not less than 10 days. Okay, and what is the objective we would like to achieve? We would like to recover the cardiothoracic respiratory system and protect the engagement of it. Okay, there should not be any kind of flaw or fallback. And what we will be monitoring is the symptoms, the heart rate, and the IPRIS. Okay, these are the things which we would be taking into consideration, right? The IPRIS is basically the psychological readiness. Now, as the term comes in, psychological readiness, can anybody tell me why we are looking forward for psychological readiness, even though if the player has been said that yes, you are ready and you can go ahead and play in the high intensity environment? Why do we need psychological readiness? Player is excited, he wants to play, we are giving him an opportunity to play, but on the other hand, we are also engaging a psychologist who will be reading and understanding his mind. Why do we need that? Anybody, please. I'm waiting. Why do we need that? Why do we need a psychologist to go ahead and observe the patient, observe the player? Why do we need the psychological readiness? Anybody? Okay, let me give you. So, oh, perfect. We've got to motivate and help return. Okay, yes, this is one of the reasons, but not the exact reason. Think a bit more. Think a bit more. The patient, the player is already motivated. He is recovered, and the doctor and the team has given him a green signal that yes, now you are free to play. You are free to perform. Okay. So he's already motivated, and we are helping him to return. So he's very happy. Then too, why do we need the psychological readiness? Think a bit more. Sportsman psychology is the main factor without which even an expert can fail. Absolutely right. Absolutely right. But why do we need a psychological readiness? Why do we need a psychological readiness? Even though the player is very ready, very happy, and super excited to hit the field. He's already ready. Then why do we need it? Psychological readiness. Any further inputs, please? I'm waiting. No? Okay, let me give it to you. Because body is now new to sport function. No. Okay, in the previous slides, I said that the patient and the athlete would be facing severe anxiety and depression issues. Okay, definitely he is overwhelmed and he's very excited because he's been given a clearance from the doctors that yes, you are ready, you are comfortable and okay to go ahead with the training protocols and the matches and the competitions. Then too, psychological readiness is important because when the player would be there on the field and he would be engaged and involved in that particular sport with a high intensity, there can be a scenario wherein anxiety can trigger and he can question himself that, will I be able to perform now? So psychological readiness during the competition is very important because you have to manage with the stress level, you have to manage with the competition, you have to manage with the anxiety of the competition, plus the anxiety within the body after the recovery as well. Right? So that is the reason we need psychological readiness, and the psychologists are always there and they gauge, keep talking to them and they gauge and create a report and send it to the coach and the crew, the medical team as well, stating that, okay, this player is fit to go ahead with the gaming as per the psychological readiness is concerned, and this player needs more counseling and more consultation to make him more strong psychologically and emotionally. That is the reason why we need psychological readiness for return to sport. Okay. Now, this was the first stage. For stage 2, that stage 2 has to be for 2 days. Now, What do you understand by 2 days? Those 2 days are after the stage 1 10 days. Okay. Now, the team, the medical team or the physical therapist has to be sure that these 2 days are enough. If he feels that no, I need to prolong the stage 2, he can go ahead for another 2-day cycle. Go ahead, observe it. If not, okay, you can go for another 2-day cycle. But if this thing prolongs, this means that either there is a problem with the protocol or the recovery has not been achieved. So you have to be vigilant enough and keep referring to your protocol, your program, and also keep referring to the physician who's actually treated that patient, right? So in stage 1, we said minimum rest, maximum movement. In stage 2, we say light activity. So light activity, what does light activity means? We were walking previously, now we are allowed to walk, jog, basic, slow or a low level speed cycling, okay, and mild to moderate resistance training. Okay, these are the light activities which can help you be ready, right? Heart rate should be around 70%. Okay. There should be increased heart rate while engaging in the activity. Okay. And what you have to monitor is you have to monitor the symptoms, the resting heart rate. Okay. And the RPE received perceived exertion scale. Okay. And the PRRS. Okay. PRRS is again perceived rate for exertion which has been achieved during and after the exercise or the training protocol or the match, whatever. That is the stage 2. So 10 days plus 2 is the stage 2. Now proceeding further, when stage 2 has been also cleared, we proceed further for stage 3. Now stage 3 is divided into 2 parts, stage 3A and 3B. In 3A, what do? Is we transit from a light training activity to a frequent training activity. So we've increased the frequency of the training. The exertion will, what is there to be done during the this thing? It should be a simple movement activities, okay, or running drills or basic treatment or basic training drills, which does not engage very high activity of the cardiac muscles. Okay, the heart rate should be achieved to 90%. So roughly it's 85 to 90. We take it plus minus 5 to 7 units. Okay, duration is less than 30 minutes. So the activity of your training should be around 30. Okay, now increased load, gradually managing the viral fatigue symptoms are the goals which we have to achieve, are the objectives. What does this mean? This means that increasing the load on the patient should be very gradual and very, very, very consistent. Listen to the patient's body as well. If the body says that yes, today is not possible, no problems, just leave the patient there and then give him a 5 minutes, 10 minutes or 15 minutes break and come back to him, say that this is important. Tell us when you are ready so that we can give it to you. Okay, so we have to understand with the load capacities also. Okay, next we have to work on the fatigue levels, because when the COVID hits on an individual, his first and foremost thing which comes in is the respiratory insufficiency and the fatigue levels. The patient is always lethargic and tired, right? And what we'll be monitoring is, we'll be monitoring the symptoms, we'll be monitoring the RPE, we'll be monitoring the resting heart rate. Okay, these are the things which we have to consider for the stage 3. All right. Now, when the stage 3 has been achieved properly with the maximum capacity, we go ahead on stage 3B. That is again for 1 day. In this, the duration of the exercise or the training or the rehab or the load has to be increased. Okay. So the protocol becomes a bit more intensive. So what would be comprised in that? that will comprise of training activities progressing from mild to moderate. Okay. And the period, the time would be 45 minutes. The schedule, the training time should be for 45 minutes. Okay. Or it can be more as well, but 45 minutes is the least minimum time. Next, what we have to do is we have to exercise coordination and static tactics. Why? Because in COVID, when the respiratory insufficiencies are there, we've also seen that the brain also gets affected sometimes, right? So we have to be really sure enough and really vigilant that it should not happen with our patient. Okay, so we have to be cautious. So this was stage 3B. Next is stage 4. Okay, stage 4 is for 2 days, minimum 2 days, right? In this, what we do is we increase the intensity of the training. Okay, we increase the intensity of the training, right? Progression has been done. Can you see there's a very smooth and a very, very silky or a very silent transition from one phase to another. Okay, now for stage 4, it is again a 2-day protocol, a minimum of 2 days. If we see, we can even prolong, but a minimum of 2 days required. Okay, now this was stage 4. Stage 5, the intensity has been increased and the normal training schedule is been achieved. Okay, now he's performing, he's training with the team, he's managing the stress level, his vitals are also normal, and things are very good. So from that, he's been given the free signal that yes, the patient is okay to go ahead with that. In the next stage, from 4 to 5, what we see is that the normal exercise which were there, which was actually allowed for the patient to perform, was being taken to a next level wherein he can train properly as per the normal routine for the athlete game. Because right now recovery is being done, but the periodization says that we are about to hit the in season. So we have to be really sure, right? So we ask the patient to please start doing this. In the meanwhile, I'll get back to you. Okay, so this is the way they proceed further. In stage 5, we basically achieve to the normality. We've got the normal heart rate, we've got the normal blood report, we've got the normal third report as well. Okay, so if not, it'll be there. So these are the stage 5 is responsible for the resuming of the normal daily protocol as per the athletic training, right? So duration can be decided as per the periodization or the plan which was being created. Okay, and what are the objectives we are trying to achieve? We are trying to achieve the respirating heart rate and RP. Okay, how do we understand by respiratory heart rate? Any input, please? What do we understand by respiratory heart rate? Or resting heart rate? So respiratory heart rate or resting heart rate is the heart rate which we calculate or we observe when the body or the patient is still stable, is not into movement. Okay, so that is called as resting heart rate. Okay, so these are to be monitored very closely. And as you can see, we started from stage 1, which was for 10 days, progressed to stage 2, which started to decrease, right? Stage 2, then stage 3. After stage 3, there is stage 3B, then there is stage 4, then there is stage 5. Okay, so the moment we are able to achieve stage 5, we give a green signal to the player that now you've been graduated and you are fit to go ahead and play in the external environment. Okay, that is what we call it as return to competition, return to sport and return to competition, right? With this, I conclude my presentation and I am open for questions. Thank you so much. Are there any questions? Yes, there are
Yes.
evidences, references to be shared. If you can proceed further, please. Next slide, please. These are references which have been used, so these can be shared to you. No problems. Any further questions?
No, sir, I think we are done with the questions.
Okay. All right. So I think we are good to go. So these were the protocols. These were the basic program guidelines, which I have personally also used and seen really good results in the patients. And through this, we are able to progress and transit from recovery from COVID to return to sport, and graduating from return to sport to a playing game scenario, hitting the field to the competition. So by this, I thank all the participants and the team, and thank you so much for organizing such a wonderful event.
Dr. Himanshu, there is a question for you.
Yes.
Okay, what about Indian athletes for this reference related? Okay, the reference has not been documented yet. We are still working, but as per my experience, I have been working with 3 different athletes who are facing COVID related issues, and this is the only protocol which I follow, and I have followed the same progression, and we've got the same results. So post-COVID recovery, we were facing functional deficit with the fatigue level issues. Plus, there were insufficiencies with the taste and smell sensories with these athletes. So what we've seen is after 10 weeks, the functional deficits were being recovered. The taste and smell came back. Although the smell came back a bit slow, but the taste came back all of a sudden with a bang. Plus, the fatigue levels were being managed with a gradual increase in the strength training protocol, as I told you in the previous slide, that 8 to 12 RM has to be achieved, and the load should be increased as per the 8 to 12 RM only. It should not be like on a ego trip that all of a sudden you go ahead and take 70% of 1 RM and start with the strength training. It should not be. It should never be being done like that, right? So soon we'll be documenting the results, and I'll share the references whosoever requires. So those would be my personal findings, my personal experience and data. So I'll share it with you guys, no problems. Can you speak about limitations and further recommendations, as we follow only 10 RM before? See, limitations and progressions, as I said, there should be a gradual progression, right? So we start with 8 RM proceeding towards 12 RM. So it is a gradual transition starting from 8 RM, one set, 8 repetitions for the initial first week. When we see that, okay, we are able to progress further, we go ahead to 10 RM, proceeding 2 sets, 8 to 10 repetitions probably for the proceeding next 1 week. So this is how we have to document the progress, the proceeding as per the what you call the RM and the load of the strength train, right? So make sure the strength load should be. Is there any EBP for 12 RM? We can go ahead. But I would recommend first achieve the threshold, and then you can go ahead with the progression further, because when you will be working with them, the respiratory insufficiencies will be there and fatigue levels would be to a maximum limit, right? When the fatigue levels are being elevated, it will be really tough for you to manage it, because there'll be gasping and there'll be insufficiencies. Plus, there'll be anxiety attacks in between. So the patient will complain that, okay, I am still facing this, so I do not want to go ahead with the protocol, right? So I would say that first achieve these targets and then go ahead with certain other progressions. I hope I was able to answer your question properly. Are you satisfied? Is it allowed? Is it allowable to format to all athletes? Yes, yes, yes. You can use this in all athletes because they are recovering from COVID. They have recovered from COVID or recovering from COVID, and we are proceeding towards the return to sport protocol. Okay, so you can use these with athletes who are into contact sport, with individual sport, or even with the shooting athletes, badminton players, or chess players as well. Okay, so yes, you can go ahead with the format with all athletes, multidisciplinary games as well. Yes, it can be provided. It can be provided.
So I guess we are done with the questions. And
Yes, sir.
thank you, Dr. Himanshu. It was a truly amazing session. It was a wonderful session.
Thank you
And
so much.
now I would request Dr. Monima to extend the vote of thanks. Over to you, Dr. Monima.
Thank you, Himani. Firstly, I wish everybody a happy World Physiotherapy Day. I express my deep sense of gratitude to Dr. Himanshu Tiwari for an evidence and research enriched presentation today. Special thanks to Dr. Prabha Vinod, IAPWC South Zone Head, for joining us today. I also thank our digital team for supporting us. We acknowledge all the participants who have joined us for the session today. Thank you. Thank you so much. Have a good night.
Thank you so much, ma'am. And it was really a pleasure to be there with such an energetic and motivating team. And I wish a happy physiotherapy day to everybody. And I thank Dr. Manjula ma'am for giving me such an opportunity. Thank you so much.
Thank you, doctor. Thank you all. Should we close the session now?
Yes, ma'am.